So welcome everybody. Welcome Trish and Victoria. Could you each tell us very briefly a little bit about your work, your research, and in particular, how you've been involved in digital health in recent years and the types of studies you work on?
Yeah, sure. So yeah, I've been studying technology for a very long time. So I'm a medical doctor by training, and I suppose I got into the study of tech through the study of evidence-based medicine, of all things, because one of the areas where the EBM, the classic EBM approach seemed to slightly break down was in the implementation of technology. You know, you can do a randomized controlled trial, which demonstrates, for example, that a piece of technology seems to be associated with significantly better outcomes, but that actually doesn't tell you how you're going to make it work in the real world. And it was the real world that I was very interested in. You said, Paul, I study technology projects that go badly. I don't start off by doing that, but it is true. You know, I used to go to parties and people say, well, what do you study? And I'd say I study failed NHS IT projects. But that's not what I set out to study. And in fact, I've moved in the last few years into something called action research, where you, the whole point of it is that you take a bit of responsibility alongside the people that you're studying to say, look, we're going to try and help you make this work, rather than just write clever academic papers about how and why you might have screwed up. Yeah, so with COVID, I've been really quite interested in how this is really the technology pandemic. It's the pandemic where in every aspect of it, you know, detecting it, treating it, monitoring it, overcoming the kind of various issues around it, it's been technology that has parachuted in as the potential savior, the technology as superhero sort of thing. And in many cases, technology hasn't quite come up to scratch. And that actually is what Victoria's writing the book about. So I think I'll hand over to her.
Thank you very much, Trish, and hello everybody, and really delighted to be here. So I'm a social worker by qualification many moons ago, and my PhD was in the social sciences and on the topic of digital mental health. Previous to that, I worked in the NHS in various sort of innovation strategy and corporate roles for 20 plus years before joining Mindwaves, and we're a digital health company that works primarily with the NHS. Prior to that, I ran an NHS-hosted digital health consultancy called Mindwaves, and we focused on everything apart from the tech, so everything around the tech, and in particular, sort of human factors. So when I first read Trish's NASS paper, and I've said this to her before, it was just like our whole experience at Habitat all in one paper. So I approached Trish and we started working together on looking at its application in practice. I've always been really interested in evidence, and in particular, I guess, how one can take a pragmatic approach to generating evidence. Because often innovation is coming from startups, small SMEs who don't always have evidence at the forefront of their minds, and they don't always understand about how to go about collecting it. So when I started collaborating with Trish, I got really interested in how you might bake in evidence right from that very early sort of concept stage, design and development stage, being sort of clear about the problems you're trying to solve, for whom, and how you would know if you're being successful, and taking into account complexity. So all the real world stuff that Trish just referred to.
Well, thanks very much to both our speakers. And I think with those introductions, I think we'll get going with the first question, which is about the COVID context and evidence generation. As Trish said, the technology pandemic. And I was going to ask both of you about your observations during the pandemic, what's happening about evidence generation to support the massive implementation of new digital technologies within healthcare systems and clinical workflows. And maybe start with Victoria. Can you, would you like to comment on that? And in particular, can you think of an example of good practice and briefly describe it to us?
I've been fascinated how COVID has seen some rapid adoption of some fairly basic but useful technologies that many of us were using in our everyday lives, such as video technologies as being the most obvious one. Although I think the evidence shows that even though we've got big adoption of video consultation technologies, we're still, for the most part, GP practices are using telephone calls as a primary sort of method. As I said, I'm really interested in human factors, and I am a bit of a pragmatist. So I really like the qualitative research that came from National Voices, and they did a webinar, which I think was recorded, which was really fascinating. And that's about people's experiences of video consultations, so patients' experiences, particularly in primary care. And what it showed was a lot of nuance, I guess, into people's very diverse experiences, which were influenced by a whole range of sort of socio-demographic factors. But also, I think what was really striking to me was, and it comes to Trish's point as tech as superhero, is actually where people had poor experiences, it was as much as how the technology was used. It was everything that went around the technology that led up to it, that managed people's expectations about what happened afterwards, how clinicians utilise the technology that was as important, if not more important, than the technology itself. For my book, I've got a whole chapter on video consultations, which Trish is very heavily quoted in. And I've been interviewing a lot of practitioners about their experiences. And I was really struck by one consultant rheumatologist who I interviewed, who was a big fan of technology. He's a CIO, but he told me about some of his patients who he's had a relationship with for many years. They say things like they love the smell of his aftershave. It's comforting to them. It's reassuring. And it led to me to wonder about those more sort of kinesthetic and olfactory components. You know, we've got the auditory and the visual to some degree through video consultations, but what about those? What about the sense of smell, about those sort of more subtle things that are all part of our experiences of those interactions? And what are we gaining, but what are we losing? And how do we weigh these things up and understand them? And I think we do need to be really cognizant of these very sort of qualitative aspects to technologies, because otherwise we're going to end up with very tech determinist targets that everyone's going to be driving towards around uptake of video consultations that doesn't maybe understand or appreciate or account for the nuance of people's varied experiences depending on their particular, the personal factors that are associated with themselves.
Well, thanks, Victoria. And I think this human technology interface is absolutely critical, as you say. Mm-hmm. Interesting to see how we come back to that in future discussion. Trish, your thoughts about the COVID-19 pandemic and how it's and perhaps tell us about some of the consequences of implementation where there hasn't been enough evidence to support it.
Well, yeah, I just want to pick up on what Victoria said. In my experience with technology, I mean, there has been a huge expectation kind of packed into technology because, I mean, partly because of our Secretary of State, you know, in the UK, you know, he is Matt the App, he is really passionate and keen and a great sort of advocate and supporter of tech. So, you know, I've got sympathy with that. But Matt is a bit naive, and I'd say it to his face if he ever invited me round, if I wasn't wearing a mask. He does tend to think that the technology is going to drive the change. And of course, we all know tech doesn't drive the change. It's a tool, it's important, but unless you've got a wraparound program of co-design, development, embedding, quality improvement, it's not going to happen. We demonstrated this recently in Scotland, actually. We went up to Scotland, had a lovely time up there in November, evaluating what Scotland had done to implement video consultations. And what they'd done is they put someone in charge who was a passionate quality improvement person. She knew all about the idea of involving local staff and patients, and really thinking of this as a service change for which the particular technology, video consultations, was one component, but it was also about, as you said, Paul, workflows and who does what and how people interact with whom. So that was a really good example of a country, in fact, and a service that was ready to hit the ground running when the COVID pandemic struck, and suddenly there was even more of a good reason for doing video consultations. And Scotland really did, in the space of a couple of weeks, set up video consultations right across the country in both primary and secondary care, actually to a lesser extent primary care, but certainly in secondary care. So that was all great. But let's go back. Even before the NASS framework, before any of the stuff I did, in fact, even before I was born, Everett Rogers developed a theoretical framework for innovation, diffusion of innovation. It's a great book. And he wrote it, I think, in the 1940s or early 50s. And one of the things he showed was that the attribute of an innovation that determines how quickly and how fully it gets adopted more than anything else is something called relative advantage. And that doesn't matter whether you're talking about hybrid corn, which he was, or whether you're talking about video consultations. Is this better than the way we were doing it before? That's relative advantage. Now, what happened with COVID was suddenly the relative advantage equation for that particular technology changed dramatically. It was suddenly really, really dangerous to see patients face to face. It was suddenly really, really good to see them remotely. So that, more than anything else, was why video got taken up. Of course, it didn't get taken up everywhere because all sorts of reasons, which Victoria's written a book chapter about. But just to come back to the smell, it's not just aftershave. There was a case recently of a 7-year-old boy completely well until 2 days prior to consulting. He developed voracious thirst, took to his bed, wet the bed, never done that since he was a toddler. And the family had a remote consultation. I think it was actually by email followed by phone, but I'm not sure video would have made that much difference, because guess what? The child 24 hours later was dead from diabetic ketoacidosis. And the two times in my life when I've diagnosed new ketoacidosis in a child walking into a GP surgery, you could smell it in the waiting room. So just to, support Victoria's idea that we use our senses in the consultation. I mean, the patients do too. They like the smell of the doctor maybe, but also it's something we were taught to people who are not well actually smell a bit weird, and you can't pick that up by video. I've forgotten what you asked me, Paul.
No, you've done it. You've done it. I mean, I think we'll come back to, I was going to ask you for examples of where things haven't worked, and you've just given us a beautiful example of where, but I want to get us, I suppose, back into evidence and evidence generation. You've certainly, both of you, talked about that to some extent. Victoria, I didn't want to jump over you. Did you want to have a comment quickly on that?
Well, a quick comment, and I guess something I've seen less is about the impact on practitioners engaging in, as we are just now, but doing clinical work online all day. And there's been quite a bit written about Zoom fatigue, and I think there's some work to be done, and maybe it is already being done, and Trish, you will know about it if it is, about the impact on practitioners doing their work in their own homes, day in, day out, sort of back to back. And I guess there's some things to learn there as well.
And I think the audience will probably want to pick up on that too.
Mm-hmm.
So let me move on, if I may, then to the second area, which was really making the right choices about digital evidence generation. I suppose that's where the title of the seminar, No Magic Bullet, came in. But digital health developers often ask about evidence generation, what's the least I can get away with? And it's exactly what you were saying, Victoria, earlier about baking it in, if you like, at the earliest stage. It often comes as an afterthought. Trish, in response to that, what advice can you offer to help them address the choices they need to make without getting overwhelmed?
Well, actually, someone asking what's the least I can get away with, I don't think that's such a bad idea, because one of the other things that Everett Rogers came up with in terms of attributes of innovations was low complexity. And that plays out really importantly in the contemporary healthcare environment, where we are in a situation of hypercomplexity. By complexity, I mean interrelatedness of multiple different factors, each of which influence all of the others and affect the preconditions for any kind of change. Now, there's a trend to sort of say, oh, well, let's make everything interoperable, for example. Let's add bells and whistles, because you can do that now. You can get some really fancy tech. But as anyone knows who's tried to get their elderly mother-in-law to use a mobile phone, what you want is something with 3 buttons, and that's all. You want something really, really simple, because if you do that, more people will be able to learn how to use it. And also something that is minimally tethered, shall we say. I've got an example, actually. I like this example of New Zealand, where New Zealand was the first country to get electronic patient records that you could exchange between hospitals and also with GP practices. And the way they did it was they held back from exchanging any kind of coded data. What they did was they had a quick verification process where you had to show that you had a legitimate reason for wanting the data. And then what they did was they printed a PDF of the particular section of the record that you wanted. And they sent that PDF, so just a photograph, and then that got filed at the other end on the patient's record. Now you say, well, that's really old-fashioned, but actually it was so much simpler than trying to align coded data between different organizations with different information governance rules, et cetera, et cetera. So just, you know, the idea that people want to make something minimalist, that is really, really good. And when I've seen tech projects fail badly, it's because they were over-ambitious technically, over-ambitious in terms of the number of organizations, the number of sign-offs, et cetera, et cetera. So I think we really do have to balance, you know, the nice to haves against the must haves in designing and developing tech.
Thinking about the evidence generation side of it, I mean, lots of people assume that they're going to have to do randomized controlled trials or not do anything at all. And I guess your suggestion that actually low complexity is best would apply around evidence generation too. Neelam has done a lot of work looking at evidence standards frameworks for different kinds of health technology applications. What's your advice to the person who says, look, I don't want to do this, or if I do, I really want to do the minimum?
Yeah, no, this is a really, really complex area. And I think it would be better to talk about a very specific technology. I mean, basically, there's 2 ways of doing this. One is that you can treat it in the abstract as a kind of theoretical experiment, as if the technology is some kind of drug. We randomize the patients to either using this app or that app or no app, and see, you know, predefine a primary outcome, all that kind of thing. That's not necessarily wrong, but as I said, it won't tell you whether this is going to be useful in the real world. The other way of doing it is a real world case study, the suck it and see approach, the what Enrico Coera calls fail early, fail often. Now, of course, if you've got the kind of technology that could do harm, and you know, there are times when you are going to need an RCT, and that's exactly what that evidence framework is all about. I haven't got it in front of me, but there are certain areas where you think, yes, we need an RCT here. And people are pretty good at doing RCTs of tech now. There's quite a literature on the methodology of that, but there is also a need for real world case studies exploring the interactions and interdependencies of all kinds of issues. And one of the approaches that I suppose I and my team pioneered was the detailed microanalysis of very, very small social situations, because you can often get the world in a grain of sand there. We published a paper, see if you can dig this one out, Jean. It was called, we call it the Dead Philosophers paper, and we published it in about 2012, I think. And it was all about the National Programme for IT, where a subcontractor had driven all the way up the M6 to somewhere near Manchester to do some what they called penetration testing, see if you could hack into a particular bit of the National Programme for IT. And they walked in there, and the people in this NHS organisation said, well, we don't know who you are, but we've got a live system here and you look like a subcontractor, so we're not letting you loose on a live system because you might kill some patients. So the subcontractor got back in their little white van and drove back down the M6 and told Connecting for Health, as it was then, well, we couldn't do it, but you've still got to pay us because we made the journey. So we actually unpacked the whole of that because it revealed the very complex kind of accountability structure in the national programme. It revealed all sorts of issues around information governance, but also the practicalities of any kind of testing on a live system where patient care and welfare was at stake. And so the dead philosopher was Wittgenstein, but you don't need to know that really. It's just a good way of finding it if you want to stick it into Google Scholar. But all we did there was we analysed one situation that took about 20 minutes of someone being told, no, you can't come in through the door. But that told us an awful lot about the interdependencies in the system. And that was a million miles away from an RCT. But we published it in Millbank Quarterly, you know, which was a top American health policy journal. So someone thought it was, you know, proper science.
It seems a perfect cue. Thanks, Trish. I think this is really, really important. And Victoria, you were talking earlier about qualitative research and the need for this kind of approach. Can you give us a couple of examples to illustrate this sort of practical advice to developers, and particularly, I guess, the role for qualitative approaches?
Yeah, I mean, I 100% agree with everything Tricia said, and about I love that sort of concept of drilling into a granular sort of a bit of a process and understanding in its entirety. I think I do a lot of mentoring with startups, and I always advise them to think about baking in an evidence orientation right from the get-go. So really starting with proper discovery and user research. People have all sorts of hypotheses and assumptions about what the problem they think they're solving and what the technology is going to do and for whom. And most of those they think are facts, and they're not. So they need to test those. They need to understand their hypotheses, and they need to test them through user research. So what problem are we helping solve for whom? How we know it's going to make a difference? What data do we need to gather from whom and how often? So it's about sort of baking in that approach right from the beginning, and design thinking and user research is its own form of evidence that helps inform in that very early stage. And as a discipline is only really starting to get momentum within the NHS. So I think NHSX and NHS Digital now, for example, are really leading those sorts of roles, but they're very rare within provider organisations, in IT teams, for example. I think that NHS Digital's design standards are really helpful. So they've got a set of principles, and again, I'm sure people can find them online and share them in the chat. But I think the third principle or fourth is design for the outcome. What will good look like? What are the health, wellbeing or other measurable outcomes that your work will impact? And it reminds us that your work should improve lives either directly or indirectly. So I guess the complexity within health is you have a whole range of different potential users. You have your end user, who's often the patient. You have your clinician, who might also be the user but might just be the gatekeeper. You might have the manager. You've got the commissioner, and they've all got different goals and metrics, and that's where you start getting that sort of complexity. But I think if you build in that sort of approach, then you start to generate evidence really at the very early stages of design and development. And then that sets you up really well for a future clinical trial or RCT or whatever it might be. But you've got those foundations in place at the beginning that you can build on. If you have to go and retrofit it, and Neelam and I have had many conversations about this, the cost and the bother is so much more. So it's about incentivizing and encouraging startups and innovators to think about this right at the beginning and build it in as a sort of core to their process.
Thanks, Victoria. I'm conscious of time, and I want to leave. There's an awful lot of stuff. I can't follow it, but I can see lots going on in the chat, including a question from Trish to me about co-production and making sure that we discuss it. I do want, though, I'm going to ask you one of the remaining two questions. I don't think there's time for the other two. But the one I did want to talk about was the collaborative work that the two of you have done, Trish in developing the NASSS-CAT, and Victoria, you in, if you like, in, implementing it and seeing how it works. First with Trish, and I think co-production is going to come in here in any case. what does NASSS-CAT stand for,
Yes, sure.
and illustrate how it can actually help digital evidence generation.
Absolutely. So there's two things. There's the NASS framework, and then there's the NASS-CAT tool. So there were two phases, and Victoria was involved very much in the second phase where we added the CAT. But NASS was originally ANASS, but one of my postdocs had an 8-year-old and said you can't call anything ANASS because it might be misinterpreted as a rude word. So we dropped the A. But if we add the A back in, the A stood for adoption, the N was non-adoption, and the next A was abandonment. So those are the things that can happen at an individual level with technologies. You adopt them, or perhaps you choose not to adopt them, and then sometimes you adopt them and then abandon them. And then the SSS was barriers to scale up, spread, and sustainability. So those were the barriers at organizational level. So those were the 6 problems, or the 5 problems we were concerned about. And really, we just wanted to, all the NASS framework is an aid memoir to think about 7 different domains that interact very interdependently. There's the illness or condition, there's the technology, there's the value proposition, which is basically all about the costs and benefits to different parties. There's the adopters, which are the staff, the patients, etc. There's the healthcare organization, and then there's the wider system. And what you have to do with the NASS framework is write yourself a story about how all those different things interact. And you could do it for COVID, actually, very, very interestingly, but we haven't got time. But that's one of the things that Victoria's been doing with her book. So we produced the NASS framework really to explain failed technology projects, which bit failed or which interdependencies failed. And then someone said, well, we want a tool that will help us ensure that our tech project doesn't fail. And so that's when we started to try and use the NASS framework prospectively when you were planning and executing a tech project, to give you things to think about it before you'd done the study. So CAT stands for Complexity Assessment Tool. And yeah, I mean, Victoria's team, she was working with a different company at the time. They got together groups of designers, policymakers, frontline clinicians, social workers. We had some patients. They occasionally invited me and my academic team. And we developed the NASS-CAT tool, which you can look it up. You stick it into Google, you'll find copies of the tools. And the Health Foundation are actually paying for us to make them electronic, so they should be available quite soon as electronic downloads.
Trish, thank you so much. Again, I'm sure that people are going to want to come back about it, but I'm keen, I think, Victoria, since you were part of this, particularly the CAT development, and you've done some work looking at how it works. Can you tell us a bit about how that worked? I think it was in relation to Habitat that you were doing.
So we worked with Trish to basically use a test, the tool that Trish, the first iteration of the tool that Trish had developed. And what we wanted to understand was how usable it was in practice. So we, as Trish describes, we got various teams. Some of them were startups at the beginning of a project. Some of them were multidisciplinary clinical teams at various different stages of either development or implementation. And we got them to use the tool as a framework for a conversation, and we observed it and then had a conversation with them afterwards, so very qualitative. And what we found, and I'm sure Trish won't be offended, was that a lot of the language was like a mystery to people. So when you talked about value proposition, the startup might understand that, but the clinician was completely confused. And then you might use a clinical term and the clinician was fine with that, but the startup was very confused. So we helped simplify some of the language, boil down some of the concepts so that they were sort of freestanding, and made it as easy as possible for people to use. And so we found out that people have very different ways of talking and thinking about projects. And I guess what this tool did was it helped people in multidisciplinary teams think about things in a more cohesive way. We used it in a masterclass with 20 or so Innovate UK grantees who were all at different stages of a project. And we just got them to do a really quick and dirty self-assessment on their own for half an hour using the NASSS-CAT. And then we got them to do some peer coaching with each other and then set themselves some goals. And they just loved it because it got them thinking about stuff that had never even occurred to them before. And then we did one with a clinical team. And they had got some national licenses to roll out a nationally approved tool, which I won't tell you what it was. But they got really empowered during the session because they realised that they had 3 or 4 innovation projects, and one of the fields, isn't it, Trish, is about capacity to innovate. And they were suddenly like, we have not got time to do this. We haven't got a hope in hell. We've got all these other things going on. And actually, it empowered them to push back and say, it's great getting the free licenses, but actually, we can't implement this in the way that it needs implementing to be a success because we don't have the capacity at the moment. So I think we had lots of different types of feedback, but universally, it was a really helpful tool to aid a conversation, reflection at different stages in projects for people to realise, to identify and mitigate risk, really, and to make good decisions about where they took projects and to think about projects in a very holistic way with those 7 factors rather than in a tech determinist way, which I think is often how people default to running these projects.
Victoria, that's really interesting. And again, I think another sort of theme coming through this is interdisciplinary, multidisciplinary approach. And just coming back to that prompt that Trish gave me earlier about co-production, were patients involved alongside and users, if you like, alongside the others in that exercise?
Where there were projects that were involving patients in the design and development, yes, they were involved for sure. Yeah.
Great. Well, I'm going to ask your forbearance in jumping the last question because I can see that there have been large numbers of bits on the chat, and I'm going to hand over to my co-chair, Neelam, who's going to be working with Henry and Jean to draw things out of that. So thanks from me, and over to you, Neelam.
Great, thanks, Paul. And so this is your chance, audience, to ping any questions on chat that you may have for Trish and Victoria, and indeed Paul and others. I think let's make this as interactive as we can. I've got a few questions actually directed to Trish and Victoria, and it's actually looking at evidence from the eyes of the payer and also CFOs. So perhaps a question to both of you in turn, and it's going back to what you've been discussing around qualitative research actually. And the question is, do payers and CFOs actually accept qualitative research as part of their evaluation of technologies? What's your experience? Trish, do you want to have a go at that, and perhaps Victoria next, or vice versa, whichever you feel?
Well, I'll say something quickly? I think you'd have to ask the CFOs. It depends, doesn't it? It depends on the culture in the organization. You know, some organizations have a very narrow view of what counts as research, but in general, when I work in the real world, people want real research. You know, of course, they're not going to turn down an RCT, but what they actually want is a kind of rich picture of what's going on. So yeah. But I'll hand over to Victoria, who probably knows more CFOs than I do.
I think everyone wants to save money, don't they? So every CFO wants there to be a health economics case that is rock solid. And in my experience, most innovations aren't cash releasing. They're very rarely, and if they are cash releasing, they're definitely not within 1 year, and that's the cycle that an NHS trust or commissioner will work to. So I think it's really important to look at the efficiencies and health economics components, but I think there is a tendency to over-deliver, or to over-promise and under-deliver, and to big up the health economic efficiencies, because those are the sorts of things that CFOs are really concerned about. But I think we've got to get much more clever about thinking about longer cycles, particularly thinking about the complexity of implementation. I mean, I think the evidence says with an EPR, it takes 10 years to realise the benefits, for example. I think Bob Wachter talked about that, didn't he, in his report? So, you know, the cycles and the way we count those sorts of benefits in the NHS do not marry up with the time it takes for technologies to accrue benefit.
Okay, yeah, no, that's very good advice, I think, and very good sort of reflections back. So still sort of staying on the theme of what is important to what evidence is important to the end user. There's a question here around what evidence do you need to make better use of tech and digital interventions? What is most useful to a clinician as opposed to a CFO, perhaps? And I realise that will vary based on technology and also what the end impact needs to be. But I mean, Trish, and particularly relating to your earlier sort of comments around, you know, the physical presentation of a patient, you know, are there any sort of words of wisdom that you can share around what's important to a clinician?
Yeah, sorry, I was a bit slow with the unmute button there. I'll tell you what I've discovered about clinicians, and I speak as someone who was a clinician for over 30 years. I no longer see patients because I'm full-time academic. People talk a lot about clinician resistance. They depict clinicians as Luddites, as rather slow, as resistant to change, in the same way that some horses are resistant to going and you have to sort of drag them by the reins. And I think this is the wrong metaphor, because what drives a clinician is professional standards of excellence. And I must have interviewed a couple of thousand clinicians in the last 20 years about technology and why they are or aren't using it. And the thing that drives every clinician is this going to help me care for my patients better? Now, when a clinician says, I'm not going to use that, it's because they are concerned about things that are for the doctor in the Hippocratic Oath, for example, or in the General Medical Council's duties of a doctor. So confidentiality, for example. People worry about data loss. When we did the summary care record evaluation, that was the thing that was stopping GPs using it. So they didn't like the idea that suddenly they couldn't act as guardians of their patient's medical record, which is what, you know, professionally they ought to do. But also, certainly with remote consulting, with video consultations before COVID, people were worried that they wouldn't be able to give the patient the quality of care that they were used to giving in a face-to-face consultation. So it's not stubborn resistance out of stupidity or out of technophobia. It is a question of how professional standards of excellence play out and the balance between potential benefits of the technology versus harms and hassles. And if you start to understand so-called clinical resistance in terms of standards of excellence, you often get to a very productive place to have dialogue with those clinicians, rather than just a stuck place where they're not moving.
Just to build on that point, you know, user-centered design is about the clinician as users. So we should be designing for and with clinicians. I once sat on a panel at a conference many years ago with a GP who said, every time a new technology gets introduced, I'm told it's going to save me time, and every time it ends up adding a whole load of work to what I do. So I think, in my experience, of course, clinicians want all the things that you've described, Trish. They also want to have a workflow that doesn't have a whole load of added stuff that increases complexity, increases work when they're already very stretched and stressed. And ideally makes their work easier and helps them do the stuff they care about better. Technology should be in the background assisting them rather than a clunky thing that they have to, add extra work. I think also people want to feel competent, don't they? You talked, Trish, when we had our chat about that notion of professional shame, and it's related to the relative advantage. Like, I've got to learn a new thing, so the learning new thing, there needs to be enough advantage related to the bother or the effort it's going to give me. And I'm used to feeling really competent in my role, and I don't want to feel embarrassed or shameful that I don't understand this piece of technology. Quite a few clinicians talked to me about that sort of thing when I interviewed them about video consultations. So I think rather than casting clinicians in that sort of stereotype of being resistant, we should be developing empathy, understanding the challenges, understanding their professional, well, it comes back to the NASS, doesn't it, Trish, about professional identity, about beliefs, about values, and then looking at how technology can assist them rather than throwing it from a great height and hoping they're going to catch it.
Yeah, wow, yes, lots of things there to think about, and I'm going to sort of be challenging a little bit, because it all sounds great in the ideal world what you describe, but we know in reality it's very difficult to get co-design in place, perhaps the right clinical and academic expertise sort of early on. I mean, what is your advice, I guess, on two fronts to companies that are looking for that expertise? You know, are there obvious places to go to get that engagement early on from a clinical and academic point of view? That's one thing. And are there any instances in your mind that a company can go it on their own to generate evidence without an academic or partner, for example? You know, are there any examples of evidence where, you know, perhaps that's not necessarily needed, you know, to go back into the making it simple camp?
I kick off here. I am absolutely convinced that these things have to be done with multiple different lenses on the problem. So if all you've got is someone who's good at designing tech, it doesn't matter how good they are, they're going to get it wrong. On the other hand, perhaps that person doesn't necessarily need to get an academic involved or get a clinician involved. There may be other ways of doing it. People learn a lot from their partners. I mean, some of the best tech has been designed by someone who's been fiddling, and then their partner happens to be a nurse, for example, or their partner happens to have a long-term condition and says, well, this isn't what's going to be needed. But, you know, Bob Watcher in his book, The Digital Doctor, describes the most, I think it's in chapter 1 of his book, about how a junior doctor who also happens to have spent a year in a tech company because his brother had it or something, then has a patient die on him because of something that went wrong with the system, and then takes 2 years out to design a better system. So it's the combination of being quite good at the tech design, but also having had this burning platform of feeling bad about the death of a patient, which then sent him into redesigning a system. But it was a system that he was redesigning from the inside because he was having to use it. So it may be that one individual embodies more than one lens, but ideally what you want, yes, is someone who's got a research brain, someone who's got some kind of clinical brain, and it may not be a doctor, it may be a physiotherapist, a midwife, you know, etc. And then someone who's also got the technical design.
You often see startups who have either got someone with clinical and or academic and or technical expertise or interest. So you're right, 1 or 2 or 3 people that span those sorts of specialisms. I think the thing about co-design or user-centered design or designing with and for your users, you're having to sort of educate your market, because if you don't do it, you'll pay for it later because you'll design things that people can't or don't want to use. So it's a false economy not paying attention to that early stage discovery. And again, when you look at the NHS digital design principles, you know, it's about starting with discovery, with user research. You validate your hypotheses. You then go on to, before you even code anything, you build, develop alpha wireframes, and you only really go into coding when you're really sure that what you're developing has some utility and is usable and accessible. So I think having that rigor right at the beginning is an investment worth making for sure. And I do think it is fine to start generating that evidence internally, but you do need at some point, I would say, to start getting it peer reviewed and getting it on a more formal footing, but starting as early as you can. A lot of clients, we find, they want some evidence. They don't need really high academic peer reviewed evidence necessarily, but they do want to see that there's feedback and you've got data and you can understand how your product's being used.
Great. And I think probably finally from me, before I hand over to Paul to sum up, and any last comments that you, Victoria and Trish, may have, but we sort of started touching on skills a little bit, didn't we? And I think certainly when I was working on evidence a few years ago, there was no evidence standards per se. You know, discussions around what good look like were not often had with innovators, unless they were developing therapeutics, for example, or medicines. And now all of a sudden now we're in a environment where we're having a webinar talking about RCTs with digital health companies and perhaps innovators that are not even in the healthcare sector. So it's becoming a real sort of, I think, merging and blurring of the environment. Where do you see this innovation space go from a sort of innovator point of view? Is there a time where perhaps they're going to be qualified themselves to be doing some of this evidence generation and know very well where the clinical and academic input needs to come? Is that the vision? Where do you see this go? Very hypothetical, blue sky question, but I'm interested.
Okay, I've just put something in the chat and let me explain it. I don't think there's one way of doing this. I just put a link into a paper that I co-authored with a guy called Nick Fahey, who's a sort of regulation expert. And it's called The Bright Elusive Butterfly of Value in Health Technology Assessment. And in that paper, we've got a diagram of various points in the innovation pathway. It's a kind of ecosystem. For example, you have to do health technology assessment right at the beginning in order to make some kind of case to get someone to invest in your technology. And the people who are developing tech will know this. You've got an initial assessment of how much potential has my technology got. But of course, until someone's given you some money to develop it and test it properly, you haven't actually done the whole thing. So you then need to go round some efficacy and safety studies. You've then got to perhaps get some approvals of this as a medical device if you're trying to go down that route. And once you've got that, you then have to do another lot of testing. And the place of qualitative research, randomized controlled trials, pragmatic testing, critical event audits, that is all in there, but it's in there as one big melting pot, and the precise kinds of evidence at different stages in this, it's actually a cycle rather than a pathway. The precise role each kind of evidence plays is going to be different in different circumstances. And the other thing is, of course, software is an evolving technology. We talk about the perpetual beta. It's not like you've designed it. It's not like a CT scanner. Once you've bought one, it sits there for 5 years until it becomes obsolete. You're getting upgrades on an almost daily basis. So your randomized controlled trial is problematic because you're going to be testing an obsolete version of the software because you've got to keep your intervention fixed. So these things, there isn't no magic answer, but read the Bright Elusive Butterfly paper because it's a bit of fun, actually.
No, thanks, Tricia. Victoria.
Yeah, I'll just add a few points onto Tricia's. I think we need to align the incentives and then provide the right resources. So it's great that we're now getting clearer sort of standards, but they're often locked away, hidden in websites, in PDF documents, not presented in the way that a startup would even find or engage with. So there's something about how we purpose and present the standards that people need to meet in a way that makes sense for and is usable to them. We need to align the incentives around grant funding, resources, VCs, angel investors. Are they even thinking about evidence, and are they paying for people to generate evidence? we need to make the resources available to match people with the teams that can help them. And then, as Trish says, having the right methods. So I think at the moment, it all just feels a little bit dispersed and inaccessible and hard for people to find. And they might stumble across a friendly academic, for example, or who's got an aligned interest to theirs. But I think there's a lot more we can do to make these resources and standards and so on accessible, friendly and usable to innovators, so that we're incentivizing them to think about this stuff really early on, rather than making it hard and a barrier.
Great. Thank you for that, Victoria and Trish. And with that, I'd like to hand over to Paul for a few final comments and a wrap up.
Well, thanks very much, Neil, and thanks very much, Trish, Victoria, Jean and Henry. Really, I hope everybody who's been involved, I've seen that you've all been, not all of you, but an awful lot of you have been engaging in the chat. It's very lively. I know that Henry's going to send round a resume of that chat, but just to sort of reflect, lots of messages coming through this. I think we knew it was going to be an invigorating session. My goodness, it has been. The sorts of things that I've heard was, I think it was Victoria who talked about the real need at the very beginning to bake in the ideas about evidence generation from the very beginning. Trish's term of transformation of relative advantage because of COVID, clearly tipping things on the side of digital. And actually, you know, COVID meaning that we have a digital pandemic as well as a COVID pandemic. I think all the way through we've been hearing about the need to adopt a qualitative approach, something that explores the human interactions, not just the technology itself. And I thought those two examples of the aftershave on the one hand and the ketoacidotic child on the other really kind of illustrate. But I think it goes well beyond just another sense, an olfactory sense. It's about that human computer or digital interaction. I've been very struck how much both the description of the NASS and the NASS-CAT and everything that you've said has talked about the need for co-production, user-centered design, taking account of clinicians, patients, and others. And I think, Trish, you talked about the multiple lenses that are needed to look at and shed light on the way something is working and is likely to work, research, clinical, and technical. I think that that last set of points is absolutely fascinating. The idea that we are becoming familiar with a whole set of standards and frameworks, which thank goodness are emerging. They are imperfect. They'll continue to be imperfect. But on the one hand, I think the point, Trish, that you raised, that this has got to be by nature and by definition, cyclical rather than linear, not least because the interventions themselves are inherently unstable, but because of the way that these things develop. And the last thing, I think, I can't tell you how much I resonate with you, Victoria, on the need to align presentation, funding, resources for matching people with teams. And it's just a chance for me to plug what we've been doing in the DigitalHealth.London evidence generator, which is exactly that for our teams of SMEs in the cohorts. And we're now thinking quite hard about looking for partners to develop something much more national, a national hub to do something of that kind. So thank you again. I think a fascinating discussion. I hope that our listeners, our audience, participants have enjoyed it as much. There'll be plenty more. I think there will be opportunities for the chat to continue. This winds up the fourth of our initial 4 in the series that we're hosting. We're going to be planning certainly another few, which will go up on our website. And I think that is, yep, that's on your screen. So please make a note of that. And don't forget to follow on the hashtag Evaluate DigiHealth. And I think the last thing that remains for me to do is to thank everybody involved and enjoy the rest of your day. Thank you all.